Hello, everyone. Welcome to OneLegacy's Connecting the Dots. My name is Tiffany Jones, and I am the public education lead here at OneLegacy. Thank you for joining today. This is our 5th discussion in the series, and I'm so excited about today's panel as we have the opportunity to hear directly from some of the leaders in our industry. We'll be discussing the state of donation and how OPOs fulfill our missions to save lives. The timing around this discussion is important for many reasons. We have COVID 2020. Many of us thought it would be short-lived, but it has become a part of our reality and a part of the way we operate our organizations and even how we interact with our local communities or our families day to day. Then it's an election year, and we all know that government does not only have an impact on one particular industry, but all industries. And there's current legislation proposals that could have impacts on the standards and processes of how we operate and conduct our business. And lastly, news stories and national press coverage, whether good or bad, our panel of CEOs will be able to use this platform today to dispel the myths and confirm the truths. I'd like to welcome our esteemed panelists, starting with Janice Whaley, who is the president and CEO of Donor Network West in San Ramon, California, the second largest OPO in the United States. Then we have Lisa Stocks, executive director of Lifesharing in San Diego. Under Mrs. Stocks' leadership, Lifesharing maintains consent rates much higher than the national rates. Sean Van Slyck is the executive director of Sierra Donor Services. While serving the broader donation community on numerous appointments on the national committee, he always is available to get it done. And then Thomas Mone, CEO of OneLegacy, my CEO, which serves a diverse population of 20 million in the 7-county greater Los Angeles area. Joining our esteemed panelists, last but not least, is Denise Pines. Denise is the president of the Medical Board of the State of California. And Denise will be hosting and moderating our panel discussion today. Before I turn it over to you, Denise, I want to remind you all that this town hall is created for you, our participants, our audience. It is created for you. And so we do have a question and answer feature where our panelists will be able to answer your questions directly. So please submit throughout the town hall. And we'll make sure once we get to that portion in the conversation that we'll be answering your questions. I am so excited and so happy to welcome the president of the Medical Board of the entire state of California, our host and moderator today, Denise Pines. Welcome, Denise.
Thanks so much. Good afternoon, everyone. My name is Denise Pines. I'm the president of the Medical Board of California. The Medical Board's mission is to protect the health care of the consumers of the state of California. And we do that through proper licensing and regulation of physicians and surgeons and other certified allied healthcare professionals. And we do this by the enforcement of the Medical Practice Act, the oldest act in the state of California. I am currently in my 3rd term as president, and my role is to ensure that we promote quality medical health care through board licensing and regulatory functions. So today we have with us the CEOs and executive directors of the California's 4 organ procurement organizations known as OPOs, who are here to share information and facts about the state of organ, eye, and tissue donation. Their main mission is to save lives. How do they save lives? Well, they do this by working in coordination with local hospitals and transplant centers to identify, authorize, and recover organs and tissues for transplantation. So now let's start talking about the state of donation. I'm going to start with Mr. Van Slyck. May I call you Sean, as I kind of want this to be conversational.
Great, thank you. Yep.
I'm going to start with Sean. So what is an OPO and why do they exist?
Great, thank you for the question, Ms. Pines, and thank you for moderating today's session. Also want to thank Tom Mone and the OneLegacy team for the invitation to join today's exciting town hall, which is shaping up to be a great event. So what are OPOs? OPOs are the federally designated nonprofit organizations whose dedicated staff serve as the vital connection between deceased donors and recipients. There are 58 OPOs across the country, each with their own designated service area. And our mission is to save and heal lives through donation. Our staff partner with community hospitals to support donor families through the most difficult time of their life, the loss of a loved one. We help to recognize and honor donor heroes who either registered to donate or whose families graciously consented to donation. OPOs are responsible for the clinical management of organ donors, allocating the precious donated gifts to waiting recipients, coordinating the surgical organ recovery, transporting vital organs to transplant centers, and providing aftercare services to donor families. OPOs are additionally responsible for providing public education about donation to the communities we serve in an effort to increase the number of people registered to donate and ultimately increase the total number of lives saved through donation. We're incredibly fortunate to have Donate Life ambassadors on our teams and joining us today, I believe, as well, who help support our education efforts with our DMV partners, our high school programs, faith-based outreach, and other community events. Before I close, I thought it'd be interesting to provide a few facts about donation. The youngest age someone can register as a donor is 13 years of age. One donor can save up to 8 lives through organ donation and heal more than 75 lives through tissue donation. Last year, the 58 OPOs across the country recovered 11,870 organ donors. And this year, we're projected to recover about 500 more organ donors. For the 4 OPOs that are represented on this town hall, last year we were responsible for recovering 1,171 organ donors. And I'm pleased to say and see that this year we are projecting out to recover about 80 more organ donors than last year. So both locally here in California and across the country, OPOs continue to increase donation even in the midst of a pandemic. And so I think this speaks to our unwavering dedication of our teams, the commitment of our hospital partners, and the incredible generosity of our donor heroes and their families.
Thank you, Sean. I'm sure a lot of people weren't aware of how one donor can save up to 8 lives through organ donation and heal more than 75 lives through tissue donation. That's just amazing to me. Ms. Stocks, I want to direct this next question to you. So Lisa, Sean shared how many lives can be saved or healed. So is there a shortage of organs?
So that's a great question. Thank you, Denise. And thanks for helping us get the message out today. This is a great format, and I'm really looking forward to hearing the questions from the audience. There is a shortage of organs, a big shortage of organs. Right now, there's more than 108,000 people on the waiting list for an organ transplant, and that's not even everyone who could benefit from transplant. The vast majority of those people on the list, they need a kidney transplant, and they're on dialysis, or they're going to need dialysis very soon. Over the last 20 years, dialysis patients have increased from 250,000 people on dialysis to 750,000 people on dialysis today. And many of those could be helped by transplant because organ transplant is that miracle that is the treatment for organ failure. More and more people could get a transplant, but the list is getting longer and longer. So what are we doing what are the organ procurement organizations doing to help this, to help all these people? And I'm really proud to say that over the last 9 years in California and nationwide, we've had sustained increases in organ donation. Like Sean said, we had increases in donation last year by 8% over 2018. And then this year, even during the pandemic, we're looking to provide more organs for transplant in California and nationally, even in the face of many transplant programs having to pause or reduce their ability to accept organs. So we were working through the pandemic to find a home for every organ we could recover. Unfortunately, even with these gains, the list doesn't just go down by that 35,000 or 36,000 transplants because more people are put on the list because more people need to be transplanted. So, so then you ask, why is this shortage of organs? And so it's really directly related to the number of donors that are available. And it's very hard to tell exactly how many donors are really available. Donors are patients in the intensive care unit on a ventilator, some sort of brain injury that leads to brain death, or the family stopping support. They have to be free of cancer. They have to have at least one organ that's functioning. So all these things are not easy to capture on a report. And so what we do is we look at some studies, and over the past several years, some studies have indicated that there could be as many as 20,000 donors. So Sean mentioned we had 11,000 donors last year. We could have as many as 20,000 donors. If we had 20,000 donors, that would be about 60,000 transplants. Still not enough. And that's if everybody consented to donation. So if we had those those 20,000 donors that made 60,000 transplants, that would be great. But right now, only about 75% of families, 75% of the time, families say yes to donation in the United States. If the patient who is a donor is not registered as a donor, the family has to make a decision to donate. And this decision has to be made during this horrible grieving process when their loved one has died. And it's difficult. And so of those 25% of the families, if their loved one hasn't registered, if they were able to say yes, that would be an additional 9,000 lives saved just from those families who couldn't make a decision because their loved one had not registered. So bottom line, to get more organs transplanted, we need to identify more donors. We need to improve the consent rate across the country. But there still is not going to be enough organs for every single person to get a transplant. We also need to help our transplant centers accept the organs that the organ procurement organizations are offering. Here's a sad fact. Last year, 6,000 organs were recovered for transplant that weren't used. They were discarded. And that is sad because those are gifts from someone who's died. And why were they discarded? Lots of reasons. The majority of those that were discarded were kidneys from older donors, and those donors had other kinds of risk factors, for example, hypertension or diabetes or coronary disease. And so some transplant centers are really adverse to taking these more challenged organs because if they don't work quickly or they don't work at all, the transplant program is going to end up being penalized by insurance companies or regulatory bodies for taking this risk that we want them to take, but they can't take because then they're going to get penalized. Luckily, I think that there's new regulations coming out soon that may help eliminate this disincentive, but it's something we all need to work on, helping the transplant centers be able to take more risks with these organs that are available. Lastly, we as a community, we need to help transplant centers increase living donation. Last year, there were only a little over 7,000 living donor transplants. And so if you put that in perspective, of the nearly 100,000 people waiting for a kidney, only 7% were able to have a family member or a friend or someone they knew help them to donate a kidney to help them be transplanted. And so I think we as a community can do better.
Thank you so much. So what I got from that is we need to be proactive about donating. And so I know we're going to talk a little bit more about how we can do that later on. Ms. Whaley, I have a two-part question for you. First, Janice, I'd like you to tell us, how does the transplant list work? Like, who gets what? And the second part to this question is, do you think race or diversity plays a role in the business of OPOs? But let's start with the first question. How does the list work and who gets what?
Well, thank you for the question, and thank you for having me. First of all, organ transplantation remains the only life-saving treatment for most patients with organ failure. A patient needing an organ transplant is usually referred by their transplant team to the transplant team by their physician. Some of the factors that play a role in who gets a transplant are age, overall health, socioeconomic status, race and ethnicity. And, you know, for over 30 years now, patients who are socioeconomically disadvantaged, living in rural areas, and racial and ethnic minorities remain less likely to be listed for transplantation. So having said that, I think every system has its opportunities, and I have seen we've all seen a move to improve the ability to have access to transplantation in this country. There've been a lot of initiatives. CMS just came out with an initiative for to be able for more patients to be transplanted, to receive kidney transplants. And as you are aware, the #1 organ that is desperately needed in the United States today is kidneys for transplant. And so the new ruling will help make sure that all patients have access more readily available to be able to be put on the list. And so, you know, there's going to need to be better evaluation processes and access so that these patients can be ruled in and not ruled out for transplant. And then finally, there's a significant need for more education and awareness on both the transplant side and the donor side that specifically targets minority communities. The fact is, ethnic minorities represent about 60% of the national organ transplant list, but only 30% of minorities become organ donors. And so there's a huge opportunity to increase the amount of minorities that say yes to donation too as well.
Interesting. So a quick question. Can I, as an individual, arrange in advance to give my organs to like my own family member?
Yes, you would need to be evaluated and they would need to do some testing to make sure that you are a match for your loved one and that you're in good health. And, you know, they have their own criteria on who can donate from living donors too as well. So yes, you can do that. And that was something that Lisa mentioned that's important. You know, we don't need both of our kidneys. So if you're able and you're healthy to donate one of your kidneys, that is a good way to eliminate the list too as well. More people donating one of their kidneys.
Great. Mr. Mone, now that we have a good understanding of what OPOs do and how they work, Tom, share with us what is the future of OPOs in, say, the next 5 years?
Thank you very much, Denise. And again, thank you for moderating this panel. You know, we are at a time of some significant change in the OPO field. From the beginning, our work has taken place almost exclusively in community hospitals where people pass away but have the opportunity to and give the gift of life. In the last 5 or 6 or 7 years, there's been the beginnings of a movement to create organ procurement organization recovery centers, where deceased donors that are authorized at the donor hospital and declared dead are then transferred to a center that is run by the OPO and enables the OPO to really focus on their donor management to maximize the viability of the organs that are being gifted and recovered. And this is actually was pioneered many years ago in St. Louis, and they have shown that there is a greater number of transplants result from this, and a higher quality of some of the organ functioning afterwards. So there's some potential real advantage here. There's probably an even bigger advantage, though, and we're seeing it right today, an advantage for our hospitals with whom we work, the community hospitals, donor hospitals, where right now there's been contention, certainly over this summer, contention for ICU beds, the need to have those beds available in case there's a surge of COVID patients, for instance. And this can happen at any time for whatever reason it occurs. So to help our hospitals who enable us to make donation happen by moving those donors out of their beds and freeing up their resources and keeping their ORs open for emergency cases will be tremendously beneficial to them. And by the same token, it's also beneficial to our transplant centers who, when they come to recover an organ for a patient who may be within hours of passing away waiting for a transplant, they don't have to be contending with other traumas in the hospital to get access to the OR. So there's a lot of potential, and we're seeing, we've opened up one in here in Southern California, Los Angeles, OneLegacy area about 3 years ago. We're building a second. Our colleagues in San Diego are collaborating with one of their hospital systems to do the same. And our colleagues in the Donor Network West have been, for a number of years, been working with a hospital to provide some space to do this. So it is the wave of the future, and hopefully it'll be really beneficial for patients and recipients and our transplant centers and the hospitals. Simultaneously, there's been some growth in the use of preservation technologies, often called organ pumping. Kidney pumping has been around for decades and has been shown to do a meaningful job in reducing the delayed graft function and making a kidney work sooner, potentially avoiding dialysis for a patient that gets that transplant, and also extends the life of that kidney from the 20 to 24 hours in which you want to get it transplanted to a little longer, so it can get to the right recipient, the best recipient that matches. We've seen some really tremendous progress made in lung pumps, where a decade ago, we sent a pediatric heart that had no recipient here in Southern California. I mean, lung, excuse me, in Southern California, to Toronto, Canada, where they transplanted because they used a pump, their lung pump. They were able to get this to a patient who otherwise would have passed away without it, and we would have had to discard that organ because there was no match in the country. So that's beneficial, and we're seeing that beginning to spread around the country, and that'll make a big change. We're really hopeful, in fact, in California in particular, that the work on liver pumps that provides a normothermic at normal human body temperature, pumping of livers that are recovered, will improve their function. We have a high rate of what's called fatty liver disease in layman's terms, largely in the Hispanic population in particular, just a genetic, as well as dietary, but largely a genetic factor. And it shows up a bit in the Asian populations, and it's an opportunity to potentially recover and be able to use livers that today are not seen as medically viable. So we're very much looking forward to that because we do have tremendous needs in those communities in themselves for these liver transplants.
Great. So it says, sounds like technology is the new frontier in this space.
Yeah, I think there's and then there's behavioral aspects. We have, all of our work, and it depends upon it. We talked a lot about a collaboration with hospitals, the donor hospitals in the community that are treating patients who've suffered a severe neurologic injury and they're on a ventilator and unfortunately cannot be saved, but those individuals can save someone else. There has been a huge amount of work and accomplishment over the past 20 years in increasing that collaboration and getting earlier and earlier referrals from hospitals and making sure we're part of that initial conversation with the hospital and families when they're talking about end-of-life planning. Families don't need to be surprised after they've already decided that my loved one is not going to survive, that, oh, wait a minute, you got to talk to the organ donation people. We need to be a part of the whole conversation. And that is probably our biggest, one of our greatest opportunity. It may be even greater than technology here in increasing, filling that gap that Lisa talked about the available possible donors versus the 25% that aren't recovered today. That's a real opportunity. I think we do get asked, I do get asked regularly about, are we going to put in presumed consent in California? Some number of us remember we were asked that by the Governor Schwarzenegger when he was here, because he said, like they did where he came from in Austria. It is often seen as this sort of tremendous panacea. It'll solve the problem because everybody will be a donor by law. And that's, it'll come up again. So in the next 5 years, we'll deal with it again. One of the things we do know is, while presumed consent is very common in the laws of Europe, it is actually in practice that every single country that has in their laws still follows the wishes of the family. And therefore, they simply have the wishes of the family. We in California, we in the US have a unique advantage, which is the fact that we follow the wishes of a donor. Someone who is registered as a donor, someone who has their pink dot on their California driver's license, that is the legal equivalent of their advance directive for healthcare. And it says you will be a donor, and no one can overturn that, not the hospital, not the state, not your family members, because that was your legally registered wish. And in a certain respect, I think that it demonstrates something that's core to our values as Californians, as Americans, that we respect the rights of the individual. The government is not going to have the right to take your organs, and they don't really do it in Europe. And but the individual has a right to say that they want to donate. And I guess I'm very pleased to say that the U.S. has a higher actual donation rate than any country in the world. In the last year, the number of deceased donor transplants per million population was 109 in the U.S. 109 transplanted organs per million population, and the closest country in the world was Spain at 100. So this notion of people making their own choice to be a donor actually turns out to be more beneficial. But this brings me down to my last point about the next 5 years. If we're going to close that gap at all, we need to move from the 156 million people in America who are registered, or the 16.8 million Californians who are registered. We've got to push that up closer to 200 million across the country, and maybe 22, 23 million in California. That's what we need to do over the next 5 years.
Wow, that's aggressive. I'm going to open this question to everyone. Is the donation system really working? Lisa, let's begin with you.
So is the donation system really working? I think that the OPO system itself works well. I think there are areas of improvement, absolutely. In any business, there's areas of improvement. And in our business where you're saving lives, you always want to be doing performance improvement. I think that, as Tom said, over the next 5 years, we'll only get better. I'm really excited about the changes in organ allocation so that organs are going to the sickest people who need them the most. And these will get more and more specific over the next couple of years. And so I do think it's working. And I would never say that it's perfect, because then we're not striving to get better. And that's what I think is important about all OPOs, is that they strive to do better.
Great. Janice, did you want to weigh in as it relates to communities of color?
One of the questions that you had asked me earlier was, do I think that race or diversity plays a role in the work of the OPOs? And yes, I do believe it does play a role. I think we're at a crossroads now where we have to take a serious look at what that looks like. And we have to look within our own organizations and look at it to see whether or not we represent the populations that we serve. Mm-hmm. So, you know, and then we need to make changes and not excuses. I think we're all working towards the same mission, and therefore it's time for us to address these issues. And there's so many studies out there that talk about minorities, and they're being more open to discussion when they're talking with people of their same race or culture. And it's important that we identify a way to listen to what their concerns are and their challenges are, and keep plowing at how we can get communities to see the benefit, because there are a lot of people waiting on the waiting list, and our matching is a little bit unique. And so minorities tend to wait longer because of the matching issue when it comes to, in particular, kidneys. And so it's really important that more minorities donate, because it will help reduce the waiting list with minorities too as well. So we do tend to wait longer because our matching is different and unique.
Okay, great. Sean or Tom, did you guys have some thoughts on this as well?
Yeah, I think what's been said so far is our experience shows us that we've had 9 consecutive years of record-setting increases in donation. We're on pace for our 10th year of record-breaking donations. And as Tom said, we're the world leader in deceased donor transplant rate. So I think though that would suggest that the system is working. Yet, as Lisa indicated, we still know that there's 22 people a day that are dying, awaiting transplant. And so clearly there's a lot more work ahead of us to bridge that gap. I think we are all clearly committed to the urgency around increasing donation. And as we've been talking about, you know, we need to continue to focus on technology, public policy, key hospital and community relationships. I think another one I'd add to the technology aspect is we rely on a bit of an antiquated system where the hospitals have to call us to identify a potential patient. And, you know, there's been work afoot for many years to try to utilize the electronic medical record systems that are in hospitals to link up to our systems so that human error is taken out of that equation. And so I think that's just one more example of the work that we're focusing on more so these days to really make sure we're getting every single referral and have the opportunity to get in front of and have a conversation with every potential donor family.
You know, I would have to, you know, build on what Sean's saying there and going back to what I was commenting earlier. The collaboration with hospitals is the core of making donation happen. The back end collaboration with transplant centers is pretty much written into law, and that structure is pretty solid. The relationship with hospitals is probably a little more fluid and a little more flexible than it should be in terms of ensuring that everybody who could be a donor is referred on a timely basis, and that the hospitals themselves are tracking their own referrals and the success of enabling donation. Moving forward with hospitals automating their referrals to us would be fantastic. Right now, we would all love to have hospitals work and send in the same reports they send us, send them into the federal government, to the Medicare program that oversees us, to say, these are the number of referrals that we found. and help hold us accountable to that. And at the same time, ensure that they are paying more attention to the referral side of this equation, because that's where it all begins. And that's part of our job, and this is part of our greatest work, is helping make sure that our hospitals realize and recognize every day that when we're taking care of a donor, we're also taking care of a recipient who lives in the very same community and lives and utilizes their services, or will utilize their services in the future. So it is a part of their caring for their communities as well.
Yeah, and I would just add, if you don't mind, that, you know, there needs to be more joint accountability. Historically, you know, we are regulated by CMS, and we're subjected to pretty heavy regulations. But on the other side, when hospitals are not referring, we don't see that same accountability. And I think there needs to be joint accountability, both to us and hospitals, to make sure that we're not missing referrals. There are a lot of referrals that we miss. And during COVID, that has been one of the challenges, because hospitals were like, well, no, some hospitals are like, we can't do donation right now. We're heavily impacted by COVID, but people are still waiting. People are still dying, and we are essential workers, and we never stopped working to do donors. And so it's really important that we focus on a joint accountability system where both parties are held accountable for potential donors. And right now that system is not as balanced as it could be. And so that it truly is an area of improvement that will help us further the work and be able to increase donors if we're called.
So what's the win for hospitals? I mean, how I hear, you know, you guys have really explained that hospital collaboration is really important. So what's the win? I mean, how do you get them to, you know, not be regulated or forced to, right? Yeah. I mean, I sit in the regulatory seat, so I know what that means when, you know, sometimes you've reached the point where nobody can agree. So now we have to regulate it and put some punishment on that, right? So what's the win for hospitals that would make them collaborate with you on a basis that's more win-win? And anybody can answer that.
So I think the inspiring mission that we have, the ability to have a family who has lost all hope in a senseless tragedy and be able to work with the hospital to give them some hope, and the fact that their loved one can leave a legacy through donation and transplantation. And then, you know, Tom mentioned earlier, we have all these new devices where there's a potential for us to do even more, recover more organs from donation after circulatory death donors, which is a unique type of donation. Our ability, the other day, we recovered, you know, a heart from a DCD donor, and the family, the hospital, everybody was so encouraged and so inspired that they were able to do that. And so I think as we do our education within our hospitals, them understanding the critical need and them understanding how they can be a part of this move to help patients that are in need and that are dying every day. That's our mission. And that is something that I feel inspires me, and I think it should them too, because they don't like telling families that they've lost their loved one. Yeah. And they can find hope in realizing that they can help us work with the family to give the gift of life, thereby leaving a legacy.
One of the things, I'm going to just say two words. One of the things that I've seen has really increased and improved our relationship with some of our hospitals is when they've taken on the honor walk. So like Janice says, hospitals, doctors, nurses, they don't like to tell families that someone has died. It's a sad failure. But the hospitals here in San Diego who have owned that honor walk, they live for that. I mean, they are planning that from the minute they talk to a family about brain death to the minute that they're able to roll the patient into the operating room. And that is inspirational enough for the CEO of the hospital to come out at 2 o'clock in the morning and stand in the hallway. That's an important part of what we do with our hospital partners.
That's powerful. So is the donation need growing now because of the health of Americans? Tom, can you respond to that?
Yeah, thank you. It's a good question. It's interesting that I think Lisa alluded earlier to the number of people on dialysis for kidney failure, tripling over the last 20 years. And there's no doubt that means you're going to need theoretically 3 times as many kidneys available than we had 20 years ago. We're about a little over 2 times what we had, but we're not keeping up. Interestingly, we're seeing some progress made in other areas of healthcare, like heart disease, where the demand for heart transplants is actually sort of flattening as there's alternatives. Ventricular assist devices and the like are getting some patients, adequate heart function without having a transplant. So we're seeing some of the areas slow down, but certainly kidneys need has gone up. And in areas like California, where we have a large Latino population with a high rate of liver failure, and other parts of the country where you see this, you see a growing need for liver transplants. And these both, the thing we all in our work all hope and pray for and look forward to is the day when we're put out of business by medical and technological innovations. We're not there yet. We're gonna need to make a dramatic effort to further increase donor potential from what it is today. From the 20,000 I think Janice spoke to earlier, and Lisa spoke to, that are potentially donors. That number's, we've got to find ways working with hospitals that number increases as well as authorization.
So is there someone in the country that's really doing this hospital collaboration really well? You mentioned St. Louis doing technology well, but is there some entity in the States, some OPO that's really have figured out the collaboration part with the hospitals?
That's a really good question.
I think every OPO has good relationships with some of their hospital systems and excellent relationships with some of their hospital systems. I think that's a challenge that every OPO director faces when a new CEO or a new system changes within every hospital, within every city in the country. I don't know of anyone who isn't still striving to get better.
Okay.
And I think that really is probably the positive point. What was it now, 10, 12 years ago, the federal government sponsored one of the greatest things it's ever done, which was the Organ Donation Breakthrough Collaborative, which brought together hospital leaders from moderate-sized donor hospitals all up to large ones and a few fairly tiny ones, together with OPO professionals and then with transplant surgeons, to get everybody on the same page and on a common linked effort to try and increase donation. And it resulted in a 30% increase. We may be at the point of getting ready to needing one of those again. And in part because one of the things we say about donation development and hospital, working with our hospitals, it's sort of like painting a bridge. As soon as you're done, you've got to go back and do it over again because there's turnover, there's change, and the rules change, the systems change, people change. We may need to reinvigorate that.
Okay.
Yeah, that was in place right before COVID hit.
Yeah.
The new CMS collaborative. So that'll launch, I'm sure, in the next year. That's exciting.
Good. So let's dispel a few of the biggest myths and misconceptions in organ, eye, and tissue donations, like the black market for organs. Share more a little bit about the pink donor dot. I mean, I know what that is, but maybe people are on who are not quite sure what that is.
The pink donor dot goes way back, almost 40 plus years in California. It was something with the DMV actually came up with back at the time for those people who wanted to be organ donors, and they had a donor card that went with it. And that, but you had the card you're supposed to keep in your wallet, and that was signed, and that was a legally binding document, just like we talked about. What wasn't really real is a little dot. You'd stick it on and it would fall off your license. It can sort of slide down and leave goop. And so in 2006, this group of the OPOs worked with the state and with the Senate and the Assembly and the governor to establish the Donate Life California Registry and link it to the DMV. So when you go to the DMV to get your license and you check the box, I want to be a donor, it puts the little pink dot under the plastic, as we said at the time, makes your pink dot stick and not slide off your license. But it also legally captures your decision to be a donor. And that when we get a referral from a potential donor from a hospital, we look up to see was this individual registered in that list. And if they are, that changes the whole nature of the conversation with the family, because it becomes one of, this is what your loved one chose to do, and here's the steps we'll go to honor your loved one's wish and help them leave a legacy and help you know that they have done something really remarkable even in their passing, to help save other lives. So the pink dot has been a huge, huge benefit to Californians. Every state has an equivalent. No one has a pink dot except for us. Others have hearts, others have other words on their licenses, but they're all now legally binding registries that work just like California's. And I think nationwide, we're at 156 million people registered.
I can, oh, Denise, you're
You're
muted.
on mute, Denise.
All right, I
There you
came
go.
back and came back on
Welcome
mute.
Okay.
I think I can answer your question. I think you were heading down the path that your father was probably asked you if he's too old to donate.
Well, it is kind of like I responded that he was too old, but he had responded about his religion.
Yeah, I could. So I think we pretty commonly see the question about, am I too old or too sick to donate? That's a pretty common question. And what we encourage people of all ages and medical histories to do is to register to donate. What we'll be able to do is determine what organs can be donated for transplant at the time of death. But around this, we can explore it a little bit more. So when you look across the country, the oldest donor in the US so far was a 92-year-old gentleman, and he was able to have his liver transplanted into a 69-year-old woman. For instance, more locally, at Donor Network West, their oldest donor was a 79-year-old individual that was able to have 3 organs transplanted. Earlier this year at Sierra Donor Services, we were able to recover the lungs from a 71-year-old donor who was transplanted into a 63-year-old. So I think those are just some examples of some of the elderly folks being able to donate. We know that people with hepatitis C can be organ donors. And in fact, in 2019, there were 1,214 hepatitis C donors across the US, and actually we're on pace for about 100 more this year. Legislation was passed back in 2013 that also allowed people with HIV to be organ donors. And so, since that legislation has been put through, there's been over 100 HIV patients that have been transplanted with HIV donors. So I think those are some of the questions that we hear from the community around if they're able to donate.
So what about that religious question?
So I'll take that, and hopefully I'm not on mute again. You would think after 8 months of this, we would be highly specialized in it. But anyway, most religions do support organ donation. Some may say they'll leave it up to the individual, but in most instances, there's probably only 1 or 2 that have been very vocal and said that they don't believe in donation. But I will tell you that even in that group, there are times when the discussion changes that thought process. And so, but there's no religion in this country that is so adamantly opposed that discussions shouldn't occur. And so we speak to all families regardless of their religious beliefs, but we, on record, most religions do support donation and highly support their congregants to be donors to as well.
Great. So that last misconception, do rich or famous people go to the top? We see this in the movies all the time.
Yeah, movies. Well, I'll speak on behalf of Hollywood. We actually here at OneLegacy created a program called Donate Life Hollywood, which that's one of the side pieces of what it does about Hollywood getting the story right and not sharing all these myths. But also, we're around the Hollywood community, and it is clearly, people see too many examples of the rich and famous getting privilege and having privilege, and that's a real world issue. Donation, transplantation works by medical necessity. I think it was mentioned earlier that people who are the sickest get the organ first. It used to be the people who waited the longest and the sickest. And that is very much the case, and it always has been. One of the cases that stands out to people that most people remember was Steve Jobs got a liver transplant. Steve Jobs lived in Northern California. His doctors told him that if he were waiting for a liver transplant there, the list was such that he would probably wait at least a couple of years for that liver transplant, and that potentially could have been fatal. As you can imagine, Steve Jobs was data savvy enough to look around the country and say, who has the shortest list where they have the ability to make a decision of who they're going to offer it to. And he found a program in Memphis, Tennessee, the only liver program in town. And it worked for him to get that liver in a more timely basis. Now, that's where privilege mattered to him. Not that he went higher up the list because he was somebody of fame, influence, or money, but he could get to a place where he could receive that transplant because he knew how to figure it out. Anybody who's on the wait list can list in other areas and list in multiple areas, and many do. So celebrity alone does not accomplish this. You would just, if you are able to get yourself to the location, you could do that. There were stories that were way back with the Major League Baseball player Mickey Mantle of a transplant, and his case was very, very closely looked at because he seemed to get it right immediately, and people said it's because he's famous. He was a famous baseball player, but in reality, he got his, it took him slightly longer time. He was a status 1, which meant you were potentially going to die within the week if you don't get a liver. And status 1 is a very short piece of the sickest people on the list. And it actually took him a few hours longer than the average. So it really was a testimony to the fact that it was really about how sick he was, not who he was. And that's really the way the list works.
Good. That's good to know. I know organ donation is not on the top of many people's lists until we or a loved one needs one. So this has been really great. I mean, more knowledgeable. I feel like I'm walking away with so much more knowledge. And I know everyone who was unfamiliar is now just even that much more knowledgeable and probably can make some decisions after listening to you all talk. So before I go to the audience questions, I want to thank Sean, Lisa, Janice, and Tom, because this has been really an amazing discussion. And like I said, I've learned so much. So I want to start with our first question. Can someone tell me how you register as an organ, eye, or tissue donor?
Oh, I can do that.
Okay.
So in California, to register as an organ, eye, or tissue donor, you can easily go to donatelifecalifornia.org and register right there. You can register when you go to the DMV. It's really easy. You can donate $2 to help the registry if you want to. If you want to register nationally, you can go to Donate Life America and register on the national list, which then gives your information. If you travel to different states, it's easier to get on that list. You can, when you register, you can say specifically what you want to donate or not donate. I do want to donate tissue. I don't want to donate this organ. That's your choice, and that's very clearly delineated on the website. So donatelifecalifornia.org.
Okay, perfect.
And I think we also, for our donate, www.donvitacalifornia.org is another site for
That's right, Dona Vida.
friends, yes.
Dona Vida, right, the Spanish language version.
Dona Vida, yeah. Dona Vida.
I know we have, so I have a question here. I am a kidney recipient. Thanks to all of you. How common are paired donations?
Who wants to take that?
I can say that paired donations is, in a certain respect, a paired donation goes back to the very first kidney transplant in 1954, where identical twins, one transplanted to the other, living donor to it, and being identical, they didn't have to be on immunosuppression. And they have grown predominantly being as directly, familial like that. In the last 5 or 6, 7 years, there's been a tremendous growth in sort of chain paired donations where one person, an altruistic donor, chooses to donate a kidney because they want to help someone. So these are remarkable people. We all want to meet them. You all need to meet them because they're the most amazing people you'll ever meet in your lives. And they start a chain, and their kidney goes to someone who needs a transplant, has someone who cares about them who will donate but doesn't match. So they get their transplant, and then the next one, that person, their loved one or friend, passes on to someone else, and so forth down the line. At this point, there are literally hundreds of these, if not thousands, a year taking place across the U.S. The largest registry is the National Kidney Registry out of New York, facilitates a lot of those, and most of these in California are done through the National Kidney Registry, which is actually enabling some almost near perfect matches and far better matches than you would normally get from just deceased kidney list or even normal paired donation. So it is a number that's growing tremendously. That at the end of the day, if we're ever going to meet the true need for kidney transplant, we'd have to have a dramatic increase in hospitals and individuals choosing to actively participate in paired donation.
Great. Another question here. I often get asked if a person is not a legal U.S. citizen, can they get a transplant and who would pay for it?
Well, that comes up fairly often because there's a question about, issues of citizenship and residency and the like, and where the organ's going. A number of years ago, 25 years ago or so, there was some controversy. Are we transplanting too many foreign nationals? You can be a foreign national. You don't have to be a U.S. resident or citizen to be listed. But it is tracked. Well, and these days it's less than 1% of transplants every year. They've been tracked for 25 years and it's a very small number. But you do have to have the means to pay for it. And if you don't live here, you would have to have your own country's insurance carry over for you or have your own source of funds. So there was a fairly large activity at Loma Linda Medical Center in the 80s and 90s in heart transplants for children. And a lot of Japanese infants came over for heart transplants because donation was extremely low there, because one of the countries whose religion, Shintoism, is one of the ones that has been one of the few in the world that does not accept organ donation. There was some controversy around that. Now the organ donation rate is improving in Japan, so there's less and less of that. But it is still possible to be a non-resident, but it's once again, it's about 1% of cases, if all.
Mm-hmm.
Okay, another question we have: what will be the impact of current organ shortage with the recent end-stage renal disease treatment choices? That takes effect, I guess. Did it take effect, or is it going to take effect in January 1st?
I'm not sure what changes those
Is
are.
this
Someone
the new model
Yes.
that the government came out with?
Exactly, the treatment choices ECTS model.
I think that was focused more on home dialysis versus dialysis centers,
Right.
but I'll leave it to others to chime in.
Yeah, and I think it focused on home dialysis and kidney transplants to help improve the quality of life. And so I think it's going to be more about access and then looking at how they can improve the quality of care and reduce the Medicare expenditures. And I'm actually reading from the press release that they had. And so basically, they're going to find ways to make sure that people have more access to care, whether it's dialysis or getting a kidney transplant.
Yeah, and actually, we alluded earlier, but probably didn't say specifically, there have been two things that have come out of this federal initiative just this past year, just going into effect now. One was changing the way transplant centers are judged by Medicare in terms of their performance outcomes. And they've been looked heavily at 1 year graft survival, what percentage of their patients transplants are working a year later. And that's one of the things that made them too conservative, because they were held to, not that they're looking at it, but simply it was held to a number that was way too high. It was for just normal distribution of organ failure. It was too high a number. The Medicare said, we're not going to look at 1 year. We're going to look at 3 and 5 year and look further out and see how you're doing over time, not just a snapshot. And that we think is going to make them a little more willing to take on some of these riskier organs to help get more of these transplants done. And the other was a group of our OPO colleagues sponsored a change in regulations that will have a new payment system for patients who receive complex organs and need to have dialysis for some period of time after their transplant, while their kidney fully recovers and takes over for them. And that's very expensive. And so sometimes hospitals, transplant centers wouldn't transplant those organs. Now we hope they will, because they'll be able to be reimbursed for some of those costs and help fulfill this greater need.
Great. Another question we have, I read that CMS is considering changes to how OPOs are evaluated. What do the panel think about these proposed changes?
I could jump in for starters if I can.
Okay, yeah, John.
Yeah, I think, certainly what I support, and I think many in the OPO community supports, is improved metrics. I think we've been talking about how we've been improving, and that's been a focus of ours. So I think globally we support improved metrics. I think the general construct of how we're going to be measured is number of donors over number of deaths. So I think generally that works well. I think what we really want to propose, and Tom had mentioned it earlier, is an accurate way to collect the data around what we believe is is a potential donor. And there's systems in place now where hospitals per CMS have to report those deaths to us. And so I think one of the considerations is we should use that system that exists and have that data reported and use that as sort of the basis for the denominator, if you will. I think there's some questions around the metrics as set up from a cutoff standpoint, i.e. if you don't meet the metrics, what happens as an organization? I think partly what we want to put forward is that if an OPO isn't meeting those metrics, there should be opportunities for a corrective plan or a systems improvement plan, albeit on a short timeline, so that you can improve to meet that. So I think those are some of the key things that stood out. Janice spoke very well earlier about part of the challenge as well, is it's really just focused on one group, you know, and I like to say that OPOs are bookended by donor hospitals and transplant centers. So I think a key part of the regulations that would be helpful to bolster is put accountabilities to the entire ecosystem. So put it on the donor hospitals to make sure they call us timely, that we can get access to donor families. There are actual hospital systems in California that don't support a certain type of donation. And that when you think about that, it's, you know, that really means that we have to change how we function. So hold hospitals accountable, hold the OPOs accountable, and then hold transplant centers accountable. So I think those are some of the key points that jump out to me. And to allow for deliberate conversation, they posted the Federal Register back in December, allowed for about 2 months of feedback from the community. I think what we want to now see is where are we at with that as well.
Okay. What is the impact of COVID on organ availability for COVID patients with lingering COVID symptoms resulting in permanent organ damage to lungs and kidneys? So we've kind of had this new group of people come into the need, right, because of the pandemic. So if everything was going as it was going prior to this, we didn't have and now a new increase in the need of this. So
we're aware of, I think we're aware of 2 cases of lung transplants
Yeah.
that have been done in COVID patients. And obviously the long-term jury's out. We don't know how well they'll perform, you know, months and a year later, but right now they seem to have saved their lives. That's probably the most emergent need. There will be relatively few COVID patients who will be suitable candidates because the disease is going to progress way too fast for some of these patients to be listed in their conditions. Their whole system conditions are so weakened. But there will be some, and obviously there are a couple pioneering and amazing efforts with these too. I think the issue of kidney failures is something that there's great concern that really the recognition that COVID is not a lung disease, not a respiratory disease, it's a circulatory disease. And that speaks to kidney function, among other things, very severely. And that could be, we could see some increasing demand from this over time. I don't know what my colleagues have experienced or heard from their medical teams, but I know we're a little concerned about their list growing from that.
Yeah, and it just brings us back to the fact that, you know, this is going to be more patients from another disease that's impacting them to actually need an organ transplant. And so that's why it's so important that, you know, donation is, you know, everybody makes a decision to be a donor because more people are going to need, you know, a transplant. But I think, as Tom said, there's a couple of places that have actually transplanted those patients, but mind you, they've recuperated from COVID and the effects on those organs cause them to need a transplant. And so it's not going to be as many people that will get to that point. As you well know, there's some COVID patients that 8 months later are still struggling with the disease. And so it also brings to mind that on the donor side, you know, we're challenged. In July alone, we had approximately 80 calls of potential referrals that met our criteria, but we could not do anything because they were COVID positive. Mm-hmm. And so the pool has narrowed a bit because of COVID. And so, you know, we're in a challenging situation. We're still doing good, but we could be even doing better had it not been for the pandemic. So.
Okay. Janice, I want to stick with you. You mentioned that kidneys were the most wanted organ donation. Kidney failure runs high in the African American community and other communities as well, but we don't register to donate as other groups do. To misconceptions and myths, what are each of your organizations actively doing to educate people of color about donations?
Well, that's a great question. I think you have to make a more concerted effort at reaching these communities, having focus groups, which we've done a couple where we meet with those communities and start chipping away at the concerns and the challenges that prevent them from wanting to donate, answering their questions, looking at finding ambassadors within those groups and finding recipients within those communities that can say, hey, I've received a transplant. It's a good thing to become a donor. And they can actually ask that person a lot of the concerns that they have. I think if we start doing this within our community, I think we'll increase donation. And we've seen an increase in donation in our diverse communities, but it's because we actually are finding ways to target those communities a little bit differently. How we target everyone is not necessarily the way to go. I think you have to really communicate directly with those communities and find what works for them, find what their cultural beliefs are. And we have some groups that will donate, but they have specific things that need to be done, and we've got to respect those things that surround their either cultural or religious beliefs when it comes to someone who is in the process of dying. And so being more open to understanding that, I remember one time it was a unique situation where a family wanted us to create clouds around the bed so that they could help that person move into the next life. And it may sound weird to us, but respecting those beliefs and making it happen, it was a challenge, but making that happen satisfied what that family needed in order to say yes to donation. And so I think it's important that we reach people where they are, we respect their beliefs, and we still make things happen as it relates to donation.
And so in San Diego, our focus is on our Hispanic community, and we do outreach through the high schools when they were open, and presenting to thousands and thousands of high school students, especially in the areas of higher diversity.
And likewise, we're focusing, we're looking at registry data to identify communities that are underrepresented in the registry and engaging those communities as well. I think something else I would add on our side that we're all doing, I'm confident, is making sure that we're recruiting, training, and hiring staff that represent the communities that we work in. So, speaking the language that the community speaks, showing up with folks that look familiar to others. So I think that's also what we're doing on our end internally.
One of the things this summer has been the Black Lives Matter movement and the civil unrest that's taken place in our community, is to say, hey, we are a part of this community and we agree with you, and let's get together and talk about where we can collaborate together, because the nature of our work, all lives matter in our world, and it starts with Black Lives Matter, and every community matters. And it's not just the policing side, it's the medical side, it's the access to care, it's your own willingness to take advantage of systems that you may not have faith and trust in. Well, how can we find those opportunities to raise the trust in our Black African American communities the way it's sort of much more naturally in our multi-generational white communities, and sometimes completely unknown in a lot of our recent immigrant communities? We have to talk to each community separately and uniquely to the issues that they are facing and the worlds they're coming from. And I think we all got I think you hear it in our talk, but we got a wake-up call to that this summer, and I think that's been a good thing.
Yep, absolutely. Someone just asked a broad question, like what's next on the horizon in organ donation? And I know, Tom, you covered that, but was there anything that you have now thought about as we've been dialoguing that you want to add to what's next on the horizon?
Next on the horizon. You know, I think the questions almost speak from a mindset that everybody wants. Everybody wants the surprise, the magic power to make it right. To, you know, fix this overnight. 2.8 million people die in America every year. There's got to be enough organ donors to go around. It just looks that it ought to be fixable. You know, we and our colleagues around the country get between 180,000 and 200,000 possible referrals every year from somebody who's had a neurologic injury, but 10% or less of those are medically suitable to be a donor. The vast majority never become brain dead or anywhere close to brain dead, and they can't be donors in that way. A few actually recover and go home, and that's the wonderful part. But that funnel is so sharply narrow. I think I would like to think that there's some way we can broaden that filter, and as we advances in the donation after cardiac death realm, and some of these are medical and technical and clinical advances, and some may be ethical discussions and advances, and those will be challenging. But but at the end of the day, there are a lot of people who, under today's current construct, couldn't be donors. But if with some shift in whether it's the pumping technology, which says you can go a little longer, even if the person, after their heart stops, and still recover an organ, that would be the holy grail, as they say. So there's some technological things there, but it may take some ethical hurdles to jump over. But we'll need to keep looking at those as well as issues of authorization, consent, and hospital referral.
And to add to that, there are some programs out there now that are looking at organ regeneration, organs that appear on, initially to not be usable for transplant, but a way in which there can be some resuscitative measures to make them better to be used. And then there is also a research program out of Minnesota that is looking and studying how bears hibernate for extended periods of time, and wanting to see if they can extend the amount of cold time on an organ for transplant. So there's so many things, nothing is definitive, but I think that as science continues to look into these areas, knowing that time is an issue with organ transplants, you have a window of when from the time it's recovered to the time you put it in. So I think everybody is looking for ways to maximize the amount of organs that can be used without the restrictions that we currently have. And so I look forward to a future where we identify ways in which regeneration can take place, and also perhaps looking at how we can get, an organ from here all the way to New York or further that traditionally we've not been able to do. So there's a lot of exciting research opportunities out there.
And that's a technology challenge.
Yes.
Okay.
Yes.
Okay. Well, I mean, we've put a man on the moon. I think we can solve this. We're cloning cats. I think there's some possibilities looming. I think sometimes things are a will issue, right? Than a can-do issue. So
yeah, absolutely.
That's where this sort of lies. So I just want to see if there's anyone. We've got about 3 minutes left. If each of you want to make sort of a final statement about the state of donations. And I'm going to end with Tom. I'm going to start with Sean.
Great, thank you. Again, I think I'm going to go back to, we've seen some really incredible growth in donation across the country. I think we have efforts. We're a unique group in that we really work to share regularly what we're doing and what we're doing well. And so I think the more that we can continue to focus on our relationships, our strategies that we're employing to increase donation, work with our transplant partners and our hospitals, again, those three estates, the more that we continue to focus on those three entities, less from a regulatory and more from a relationship side of this, I think we'll continue to increase donation.
Okay. Lisa?
I want to send a shout out here to donor families and really make sure that we as a community understand that the donor family is at the center of everything that we do. The donor has made the decision or not made the decision, and the family has to be there and has to help us walk down that road. And holding them up as heroes, I think, is an important part of what we do and communicate every day.
Janice?
So I would encourage everyone to make a decision to be a donor, but also talk to your families because there are times when you're registered to be a donor and when your family doesn't know, sometimes they're not so sure about it. So it's important that you share your decision with your family. And the other thing is that talk to each other, invite us to talk to your communities, you know, and this is to people of color, you know, you help a lot of minorities on the list when you donate. You help everybody on the list, but it's important that we as minorities increase, you know, become donors. And that's important for a number of reasons, as I discussed earlier. So talk to your families, have those difficult discussions, invite us to come talk to your community. We want to change the narrative here and make sure that everyone who is waiting on an organ is able to receive one. We know that day is not here yet, but if we all do our part and make that decision, hopefully more people can be transplanted.
Great. And Tom, we'll end with you.
My colleagues have got it so wrapped up. I think I'll try and get put the bow on it, that organ donation in its raw numbers is a sort of a blip on the radar screen of healthcare. Thousands and hundreds of thousands more orthopedic procedures occur every year, or cancer surgeries or the like. But there's no doubt that there's no story more powerful than the story of an individual and family who got someone on the brink of life and death on the donor side, and the same issue of someone who's on the recipient side waiting for a transplant. They're both at that brink of life and death. And the power of that moment and the humanity required to make something good come from that, well, it makes organ donation and transplant the #1 go-to medical story in every medical drama ever made, whether they did a good job or bad job. It is a powerful story. Yeah. And helping our communities see that, and in our immediate communities, helping our hospitals, doctors, nurses who are caring for patients in their hospitals. And when they're not able to save them, sometimes they have a sense of loss and tragedy, and it's a difficult thing. And we go back in the day when they used to actually approach families for donation. They couldn't accomplish it because they were speaking from, we're about their tragedy, and they failed. Well, we like to approach this, and we really like to position this work as it's the celebration of life. It's that legacy that you're allowing to go on. And if we can all see this, at the end of the day, it is about the life that goes on and is carried forward from the one who gives to the one who receives. And the fact that every one of us on this group has had an occasion where we've talked with a donor family that we went to offer our sympathies to and thanks to, and they've interrupted us to thank us for giving them the chance to make something good come from their loss. And if anybody in the world ever heard that, any doctor, any nurse, anyone who were debating registering, you would know right then and there that registering to be a donor is the right thing to do.
Great, thank you. I want to thank you all, Sean, Lisa, Janice, Tom, for such an informative conversation. I mean, we've gone down a pathway here from our challenges, which is the need for more kidneys, the need to engage people of color and improving the systems with people of color receiving organ transplants, to the future. Technology and more improved collaboration in this space will really change some of the numbers and the metrics that we've been talking about throughout this conversation. So I want to thank you again for the work that you do. You're saving lives every day. And we definitely here in the state of California appreciate that work. And so now I'm going to turn it back over to Tiffany for some final remarks.
Hello. Well, I'm learning. I think we all are. Denise, I want to just first say thank you for graciously accepting, this opportunity to share with our California leaders of our OPOs and just sharing this conversation with our community. I think it's so important for the community at large to hear what we have to say. And then I want to thank our esteemed panelists, Janice, of Donor Network West, Sean, Lisa, and Tom Mone, who serves here as my CEO. I just want to say thank you all, because it's important that we're making sure that we connect the dots and that our communities hear from us. This platform was created to do just what it's doing. And so I want to say to our community, listen, any questions that you guys have, any way that we can be of support and continue educating, that's what we're here to do. Please know that no question is too big, no question is too small. We are here to support and to make sure that we fulfill our mission, which is to save and heal lives through organ, eye, and tissue donation. And so while you've been here and hearing our panelists who all have, nice lofty titles, know that we also have one mission, and that is we want to make sure that you guys are knowing that you can call your local OPOs and that we are here together. Thank you.
Thank you.
Thank you. Thank you all.
Thank you.
Until next time, see you all on Connecting the Dots. Thank you.